All right, I think we are good to get started. All set on your end, Miles?
Yeah, let's do it.
All right. So again, thank you so much for joining this month's H1 Connect webinar. To get us started, I'm just going to go through the agenda, what you can expect to hear about today. We'll go through introductions, and then I'll give a brief overview of H1 Connect, specifically for those who haven't joined a webinar before or are newer to the network. We'll interview our lovely guest, and then do a Q&A at the end with him as well. So to get us started, something is wrong with his picture. Dr. Nasser couldn't join us today, but we have Dr. Saleh from FAJR Scientific. Doctor, I know we'll be doing an in-depth conversation with you later, but could you just briefly introduce yourself to the group to start?
Sure. My name is Dr. Khaled Saleh. I'm an orthopedic surgeon, but also the founder and the president of FAJR Scientific. FAJR Scientific mission is to primarily focus on providing highly complex medical care, surgical care to those in underserved areas. We have our focus was to literally hit multiple continents at different times, but we are currently working in Gaza for obvious reasons and have been the focus of our last 3 missions in less than a year over there.
Awesome. Thank you so much. And we will certainly get into the weeds, the nitty-gritty, all the details of that shortly. Just to do some introductions on the H1 end, Miles Kerwin here is our chief of staff and really leading the charge on the H1 Connect effort. And then I'm Katie McHenry. I'm the network lead of H1 Connect. So to start, I know some of the people in this group joined our last webinar, so I promise this won't be too repetitive. I'll keep this part brief, but I do want to provide an overview of H1 Connect to those of you joining for the first time. So I'll start with this slide we typically show to the NGOs we work with to describe how H1 works. So H1's mission is to connect the world with the right doctors. And there are 2 sides of the business that work together to support that mission. So over here on the right is what we refer to as H1 Connect. And that's the part of our business that this group is likely more familiar with, wherein we connect medical professionals in our network to, like yourselves, to training, resources, and volunteer opportunities with NGOs we work with, like FAJR Scientific. On the left part of this slide is the other part of our business that funds our ability to do this work. And that's wherein we connect doctors with pharma and life sciences companies for research and clinical trial work that they do. So this involves maintaining a large database of doctors. We pull this information from public registries, from hospital websites, places like that on the web. And this amounts to about 10 million plus doctor profiles. The H1 Connect network you're a part of, so the part over here on the right, at this juncture has around 4,500 medical professionals, and it's growing quickly. So I'm going to hop over to the next slide. Now that we've established who H1 is and how it works, I want to give you a little more context on how H1 Connect started, what we're doing today, and what our vision is for the future. So our mission with H1 Connect specifically is to build global health equity. So if you look at the bottom right of this slide, back in October, when conflict broke out in the Mideast, we said, hey, we have this extensive database of doctors. Let's reach out to them and see who's interested in helping, first in Israel and then subsequently in Gaza. Since then, we've expanded and built direct relationships with NGOs like FAJR Scientific, Save the Children, Team Rubicon, and others. And these NGOs support humanitarian response efforts not only in areas of conflict, but in disaster response, following something like the earthquake in Haiti, and in generally supporting under-resourced health systems across the globe with disease control and capacity building efforts. You'll see that on these subsequent 2 pillars here. Ultimately, we see a world in which we're able to start connecting healthcare professionals like yourselves who may want to engage with pharma and industry and the opportunities to work on, research and clinical trials that they present in furtherance of our mission to make sure everyone has access to the same quality of care. So I'll go to the next slide. At this stage, we're still primarily focused on the humanitarian response pillar. So that first one you saw in the previous slide. And what we've learned from working with NGOs is that following the earthquake in Haiti, a lot of healthcare professionals just went and were eager to help, which is obviously wonderful. But the lack of structure and coordination there was a challenge. So in response, the World Health Organization established the Emergency Medical Tea or EMT program. As part of that program, the WHO pushes NGOs like the ones we work with to maintain large reserve rosters of healthcare professionals who are vetted, they're engaged and trained and ready to go before one of these conflicts or disasters strikes. And maintaining those rosters is a huge lift for these NGOs. So our goal is to alleviate that lift. And build a global reserve roster that NGOs can pull from based on their specific needs, based on the work that they're doing. What this also does is provide you, the healthcare professionals who are interested in this humanitarian aid, more resources and more opportunities to connect with NGOs. So I promised I'd keep this brief, and I will wrap up with this final slide. With a summary of what being part of H1 Connect network means today and then in the future. So by joining H1 Connect and filling out the H1 profile that you're prompted to fill out upon joining, you're being pre-vetted, and the NGOs know that when considering candidates for deployments. You'll have access to opportunities with the over 10 NGOs we work with via trainings and applications posted on our site. You'll also be able to collaborate with your global medical peers. We have a WhatsApp group you can join, and I can certainly drop that in the chat in a moment, unless Miles, you beat me to it. And we'll share that in all of our subsequent follow-up communications to the network. Ultimately, what you'll receive is our ability to leverage our existing relationships with pharma and life science companies to participate in global health research. So I'm going to move over to the next slide, and this is when I will go back and forth with, again, our guest. Just a couple guidelines to get us started. So I'll start with some questions so everyone has the background information they need. And then as you have them as they come up, and it can relate to what I just said as well, post questions you have for the H1 Connect team in the chat. Miles is going to go through those, and then we'll have time for a Q&A when he can call those up. So I'm actually going to stop sharing my screen for a moment because we don't need this slide deck. Oh, excuse me, stop sharing. And then let me change this to speaker view so you can follow along. Again, hello, doctor. Thank you so much for joining us today.
Good afternoon on the Eastern Standard Time here. So hello, everybody.
Yes, afternoon for us. And early morning, late night to some of the others joining. So again, thank you for joining. So you did a brief introduction earlier. Can you tell us a little bit more about what you do, your healthcare background, and how you came to do it, just to set the stage?
Sure. So I basically trained, I am Palestinian from the 1948. My family immigrated to Canada in mid to late 60s, where I grew up. In that process, I was fortunate to get educated at one of the top institutions in Canada. During that time, it was clear that there was a lot of health economics issues and policy. Excuse me, I'm trying to control my screen here. That were becoming an issue, and therefore went on and did a master's of public health, which at the time was unheard of with orthopedic surgery. And went on to do work with John Sackett, who's one of the leading authorities right now in evidence-based. Well, he was, sadly, he's passed away. He's dearly missed, and he left a huge legacy. Sackett was able to really change the way we think about medicine, standardizing protocols and guidelines, and then putting effectiveness and costs beside it, because most of the governments were working with costs, and almost it was considered prohibitive to speak about money in the 60s and 70s and then 80s when it comes to healthcare, but it's clearly that with the limited budgets and so on. So the first study that I looked at was really looking at waiting lists and its impact on joint replacement, and it's really truly is really saving money. And needless to say, it actually hurt patients because they were delayed from surgery, and the impact was significant, and that they required more healthcare actually than they didn't, because they needed help from taking care of their house, and they had to call their daughter to come and take care of them. Well, that study was recognized and was awarded with multiple awards. And then since then, it's been used as basically a landmark that waiting lists don't work. From there, I was basically elevated to the position of consultant and have traveled around the world providing consultations from Medicare to the NHS system in the UK, Scotland, Australia, and so on. I've been fortunate to be able to be in those positions. In the process as well, I stayed true to my DNA, which was to be an academic and complex joint replacement surgeon. And after, still continue now, after 34 years of practicing as an orthopedic surgeon and training, I was fortunate as well to train at the Hospital of Special Surgery in Cornell. I went on because of my leadership positions across the country to complete a healthcare management degree at Harvard, which only is about 15 people are selected at an annual basis versus the business school, which I think they take 1,000 people a year at Harvard. And that was really specifically for healthcare leaders that have a track record. In other words, you have to be at least in leadership track with about 10 years. And since then, I've been continued to mentor and trained hundreds of doctors around the world. I'd say about 95 of them are leaders in their own respective countries, either in the ministries of health or chairmen or deans at various institutions. As part of this FAJR organization, we've been doing this for a long time in a different capacity. It was called SALA Orthopedics, Orthopedic Research and Education, or SOAR, is what it stood for. And we brought physicians from all over the world that could to access top-notch education, updates, the latest and the greatest technologies. And we did that as a non-for-profit organization. Starting in 1999 was our first course. 2000 was our first course, and then we progressed from thereafter to basically in 2018, after doing 14 courses and training 5,000 surgeons, many from the subcontinents as well as the East. And we produced CDs, we sent textbooks, etc., to help the education and the updates, because some people were unable to travel to these conferences, whether you're in Cuba or potentially costs or visas, all these, especially for the Palestinians, is an issue. 2018, we rebranded to FAJR, which FAJR, I think some of you know, is basically a time of prayer for them or the dawn in the Islamic world, but really symbolizes a lot as well other things. That is this crack of dawn when it's just the most dark. It's the start of a new day. It's the start of hope, chance to make a difference and impact the world. And FAJR is spelled just like the surah in the Quran as FAJR. With that, we have been fortunate. The growth of FAJR has started really taking off in 2018 until the pandemic hit. And our plans to start working really around the world. We had a number of countries we wanted to address, both in Middle East, Africa, and Central America, especially Honduras was on one of the top 2 in our list. We went to Palestine as a first because that was obviously a number of requests from our compatriots and our members in the organization. We did a first small mission in the West Bank, was extremely successful. We were met with significant challenges with organizational effectiveness, meaning translation. We were prepared to do 100 surgeries. We ended up doing 48 or 52 or something like that. The challenges were we didn't have the patients. We were trying to do this old model where we see the patient on the day of surgery or the day before surgery and then operate the next day, which has been going on for global health and NGOs for years. Well, it didn't work. And as a result of that, we moved forward with a different model. Dr. Musab joined us, who's a operational and geophysicist actually, and basically helped us develop this model, which we call the FAJR methodology. And if you are really interested in the details, it was just published in the top journal in orthopedics called Journal of Bone and Joint Surgery, which is a 6.0 impact factor journal. And we also published another one actually saying not our complications, but our issues in terms of not reaching our goal of 100 surgeries was in the yellow journal called Journal American Academy of Orthopedic Surgeons, 2 top-notch journals, because this work really is groundbreaking that we're doing. We continue to teach as part of our mantra and mission. We continue to publish all our work and learns that we take on and we pass out on. So we were able to complete the story in August. We were there, and I think I want to say that Miles, I think we met then sometime in August. I think we started talking to H1, and our first mission was elective, and we were able to complete 153 surgeries, which was a world record. We were published in about 80 outlets, including the Jerusalem Post, all the way to NBC, Reuters, etc. Then the war broke out on October 7th. Obviously, things changed at that point, and it was obviously to see the massacres that occurred on October 7th for the civilians, and then to see it also on the other side. As a humanitarian organization that's apolitical, that's concentrated and holds true the ethos and basically the tenets of healthcare, which is to provide care to humanity, we were moved to start doing missions. Obviously, the first few months, this was not doable because of the fact that nobody was able to travel into Gaza because the war was active. And then as things opened up and there was a rougher border allowed us to come in, we started doing our first mission, which we were, again, got canceled, got canceled, not by us, but because of various reasons. The war, it started before in certain areas, the border was closed, reopened. Eventually, we get in after long preparations and waiting into April 1st, where we did our first mission for 2 weeks. That's the one I went on. I also functioned in a dual role as chief medical officer and laid the stage for the next one. We probably treated about 200 people, complex surgeries, consultations, etc. And there was significant, we were at the EGH, which was most of the physicians there and the nurses actually had left. They were warned that potentially it may be impacted the same way as the other two major hospitals, which is the Shifa and the Nasser hospital. So they were told to evacuate. They evacuated. The only people that were left there were the NGOs, and the NGOs we were there was us and another organization. Our team had 20 people, so we manned the operating rooms with our expertise, primarily orthopedics, vascular surgery, general surgery, ENT. At that trip, we didn't have ophthalmology, but we actually had one on the second mission. I'm happy to say we probably treated over 400 surgical patients in dire distress, some of them requiring extremity amputations, young people, the majority of them, very complicated. There's no staff to support the surgeries on the ground. In other words, the surgeons are basically mopping the floors between cases. The skeleton staff that we had was primarily administrative, who gets what OR, what time, which case goes first, who's urgent. Oh, by the way, there's a case on the floor that's septic that needs an immediate urgency, and literally, these are brought in. But for us, it was a challenge from multiple perspectives, specifically the supplies, because you cannot take anything in because of something called dual use, which is on the Israeli side. So anything that could potentially be used as a secondary use in either creating a bomb or harming another individual, it was not allowed in. So simple things like scissors and so on, you cannot ship them, as we had done in the previous missions where we sent, I believe, something like 50 pallets or something like that. We had to bring it in suitcases. We brought in 8 suitcases on the first mission and 118 on the second mission. These are hand carried, and still we were limited. We ran out of anesthesia medication, we ran out of implants and so on. So this is just one of the challenges. I'm sure there'll be other questions in terms of what's going on. And as you heard now, Rafah invasion or incursion has just occurred as the second mission was in midway, just about to leave. And as a result of that, the folks in there were delayed from departure and we're looking like nowhere. In fact, some people are still delayed to this day, and they were unable to extricate from there. And since the Rafah incursion, which was now since almost in its 4th week, so they're there beyond what they had expected, and they can't leave because their embassy couldn't help or they don't have relationships with the various locals. So as a result of that, they're still there. We worked through the World Health Organization to do most of our work to enter. They have been very extremely supportive, but again, they're limited by the capability of what the status and safety of it is on the ground. So those are just some of the things, and I'll just pause there because I'd give everybody a chance to ask questions.
Yeah, thank you so much for that answer. I'm sure plenty of people in the chat will have questions to start while those get organized. So you touched on this in what you said, but I know a lot of the people in our network are quite curious about what things are like on the ground in Gaza, specifically for people who are involved in medical and humanitarian aid work. Can you tell us about that specific experience and what people interested in volunteering would need to be prepared for?
So it's a very tenuous situation. As soon as we walked into the Rafah border, we heard drones constantly about wherever we went, and most of the city, I guess the core of the city. We had a safe house which is deconflicted. As you heard from the World Kitchen, Central Kitchen, they were affected. They were basically killed by a drone. And whether it was intended or not, that still remains to be deciphered from our perspective. We really are committed, like I said, to apolitical, but we were concerned about our staff. We wanted to do our job and focus on that. And even though in our deconflicted area, we had drones the whole night going on, which is fairly loud. They're not actually, don't stop. Secondly, we had issues with regards to bombing. The bombs would start around 10:30 in the evening every night. They're quite loud. So a lot of us were not getting the best sleep. Some of us brought earplugs, and even then it wasn't enough. That's how loud the decibels were. In fact, some of the fallout was so close that it was actually hitting the building. We can hear them on the windows of the rubble, etc. At about 10:30, you lose all communications. You will also lose electricity for those that are using, for example, sleep machines and so on. That'll be an issue. And you really have to have access to clean water, and you have to have access to, obviously areas where you can grab a shower and so on. So you really need to have facilities to support that. And we were fortunate we were able to get this a safe house, like we said. But even then, a couple of times while we're staying our first mission, we stopped having water. And when it was examined, it was a bullet through the water collector system that was on the roof. So it was really challenging. In terms of traveling back and forth, it was extremely challenging for a number of reasons, because of the fact that we had issues with the pathways. So we had to work with COGAT as well as with the folks that were on the ground that were actually communicating from the WHO to the COGAT office, which is an extension of the IDF, to say, okay, now you can leave, because then we can ensure your safety. And we've had no issues from our safety perspective, but it was very, very time consuming. Sometimes we'd be waiting to get the go ahead for a 15-minute trip, 3 hours before we got into the hospital, waiting to go and do our surgery. And we had patients waiting for us. So it was very, very inefficient in some ways because of that. Secondly, once you got there, like I said, you really don't know what to expect that morning. And as a result of that, was just a lot of inefficiency. We just chose to stay at the hospital. It just made more sense to do so. At the hospital, even though the Wi-Fi did cut out once in a while, it was at least less tenuous than that up there. And that allowed us to communicate with each other. That was the number one reason. Although it's nice to check in and let the family know everything's okay. Obviously, the families are a different discussion. We could talk about that. They're an extreme amount of stress, and you can appreciate them being worried with what's going on in the situation. Furthermore, it was really it just got to the point that by staying in the hospital is ideal. Unfortunately, the facilities there are extremely compromised. There's only a couple of washrooms for thousands of people. The hallways are filled literally with people living inside the hallways that have nowhere else to go. In other words, they lost their home. They came to the hospital because somebody was injured, and as a result of that, they stayed there. They're living in tents, even though the temperatures when we were there dropped in the low 40s. And they literally, this tent is literally probably can hold a couple of us, I would say, but a family manages to live under this little piece of plastic that they call tent. And about 20,000 of them literally live inside and around the hospital, making it very difficult to navigate. You also have challenges with the people that are, from a sterility perspective, when you have that volume of patients shedding skin, so surgery is also compromised. The infection rates are extremely high in the hospital, partly because of the number of people that are living inside it, but also partly because of the fact that there's lack of antibiotics and lack of sterility disposables that you usually see in the operating room. So it's been was really, really challenging for us to go from zero complication rates in elective scenarios in Gaza and then come back and see the massive destruction. It's literally rubble everywhere the eye can see. And there's tents everywhere the eye can see because that's where people have migrated to live there. That's basically the situation in terms of challenging. In terms of food, etc., you can bring your own food and water, if you will, which we did. We're fortunate to do that, but I'm told now you cannot do that based on the new allocation of the entry from Jordan. So that's the challenge. In other words, we were able to bring in 118 suitcases plus our food and supplies. Now they're limiting this based on Jordan telling us now we can only take 2 suitcases, which basically you're now ineffective to do this.
Thank you so much. To stick on the subject of Gaza, now that you've painted such a picture of what it's like to actually work there and be there. I know you, Miles, and I have discussed your upcoming mobile hospital effort, and I wonder if you could provide some details to our users about that.
Sure. So right now there's a number of hospitals that are in the vicinity, but they're primarily field hospitals, which are made out of primarily materials equivalent to a tent. Yes, they may be waterproof, but their content is that not made to really carry out complex surgical procedures. Although they were obviously on a stretch, like the Emirati Hospital is actually almost 20 years old, that hospital, and what just brought back in as a life-saving measure. It supported a couple of ICUs, but that was it. Really, I wasn't able to do a lot of the necessary complexity that is needed. They did a phenomenal job, but really the proper mechanism is to have a mobile hospital. The difference between that is a mobile hospital is made out of fiberglass. You can create the sterility conditions equivalent to a real hospital made out of concrete. We don't know how long, even if the war stopped this instant minute, when the next bag of concrete will come back to, rejuvenate the hospitals that have been affected, if they're rejuvenatable, meaning the destruction, if we've seen, is immense and may not be easily reconstructed and may take months. In the meantime, we have, as of yesterday, over 80,000 injured, or close to 80,000 injured, not including, of course, the deaths of nearly about 40,000 now. And those 80,000 injured are basically are in 3 tiers, is the way we classify them. Acute injuries, where they basically have been affected primarily. It's usually most of the people we've seen were kids, say about 65% of them. Shrapnel is one of them, or direct bullets, shrapnel from the bombs, etc., which are very complex to remove in various areas that we had to take out from the spine, abdomens, etc. Then you have the bullets, etc. So that's the acute injuries. Then you had surgery, patients that had gotten medical care, but because of the quality of the care, because of lack of supplies, they have a complication from that, whether it's loosening of the hardware or infection. That was a second class we were dealing with. And as a third class, where actually was the chronic diseases, where patients, because of lack of access to insulin or lack of access to antibiotics, were getting infections and admitted to the hospital with simple diseases that we control in the West with antibiotics from over the counter, almost some of them. They are now full-fledged amputation needs to be done.
Great. And I'll ask one more question before I turn it over to Miles in the chat. But when we and you primarily think about staffing, your ongoing deployments and eventually that mobile hospital, what types of medical professionals are you looking for? What makes those folks successful? What types of folks is FAJR looking to deploy?
Well, thank you for that's a very important question. So the hospital, basically, as a mobile hospital, will be performing with minimum 5,000 procedures a year. We anticipate as well clinics that will be ongoing that will probably see in 10 to 20,000 patients a year minimum. And we're looking at actually putting in a second hospital in play. The key issues that we want is to continue the high quality care that we have been providing with minimal complications. It will have 8 operating rooms in each hospital. We can add more. It's a mobile hospital, so you can actually basically, it's like Lego, if you will. It's blocks, you can keep adding and expanding it. And it has 8 ICUs and 8 PACU, or post-operative care units. So that's terrific. But it also hosts at least 120 beds. And if we need to add more to it and we have capacity, we do so. So the physicians we're looking for are primarily highly trained and experienced. Experience without highly trained doesn't go together. We need to have both. So the surgeons we've selected that have been with us are people that have trained somewhere in the West, at least spent some time to do so in that sense. They spent time in France, Germany, UK, not as researchers, but actually hands-on. They have the experience as well. They're taking it, practicing in those areas, but as well potentially taking it back to their home countries. As you can appreciate, we've had multiple countries. We're very fortunate. We're very appreciative of all the doctors and the nurses that have submitted their names, but we need to make sure that the standard guidelines are maintained. So the evidence-based protocols that we adopt are basically peer-reviewed. In other words, this is what's recommended for cervical discectomy. Here's what's recommended for an abdominal, intra-abdominal shrapnel removal, or if our vena cava has been affected and it's been cut, then how to go proceed that. We have this multi-complex team that comes in. So we have a thoracic surgeon, general surgeon, as well as a vascular surgeon operating on the patients that have the same methodology. What we notice is that different parts of the world have different methodology in how to approach the same problems. That creates conflict for us. So the thinking and the mindset is, if you have, for example, the first patient we walked into was a bullet to the vena cava and the thoracic spine, which is a major injury, and we were able to save the patient, but it required several specialists. Like I said, we need a chest surgeon, you need a vascular surgeon to get access, you need a vascular surgeon in there, as well as a general surgeon to provide that expertise. They all knew the protocols. They knew exactly what the next steps were for that patient to succeed. And in the process, we saved life. This is an injury that usually has about 95% death rate, but we saved it because even though each of the doctors never worked before together, and they never were in the same region in the world together, but because they used the same methodology, they were able to execute beautifully for that. We noticed that there's different methodology. Of course, not every patient needs the same protocol than others, and there's other ways, as they say, to skin a cat. But we found that clashes with the majority of our surgeons, who tends to be Western trained, Western experienced, methodology, with access just about to the best of the best in terms of instruments and education and so on. So as a result of that, we've had challenges with some of the folks we brought, even from Egypt and so on. They just don't have that expertise. They don't have the most recent, instruments, or the most recent developed implants and prosthetics. Not to say that they're not good surgeons, just they're not used to this new materials, this new devices that's being used to have better outcomes, better capability. So we've been very, very careful about, who aligns best, because usually we found people that are trained in these countries tends to basically follow the same protocols, which makes it easier to provide care.
Great. That was so helpful for me to hear as well. So thank you so much. Miles, I think you have a question from the chat.
Yeah, just one question in the chat call. So I understand that FAJR Scientific is not an EMT classified team yet, but what is your relationship with the World Health Organization today?
So we are considered as accepted as an NGO. We are a non-for-profit organization, but we are an LLC. We are in the United States. We chose this designation to allow us to be able to navigate the challenges that some of our colleagues in NGO continue to face. But we are with the WHO. We are recognized as a medical team. We are also recognized by the Ministry of Health inside Gaza as well.
Okay, great.
We're part of the EMT teams. We are part of the EMT team protocols. We're part of the threads, etc.
Got it. Well, let's give people an opportunity to ask additional questions. So if anyone has a question, do you want to click the raise hand button at the bottom there? And then we'd be happy to promote you to a panelist and let you ask your question. Or you can drop your questions in the question and answer as well. Okay, we have a couple hands raised. Okay, do you want to promote them?
Give me one moment. I'm seeing Leslie, so I'm going to go ahead and allow you. Hi, Leslie, to ask your question. Thank you.
Yeah, hi. I'm hearing a lot of physicians, but what role in the nursing population do you need? Are you looking for?
Surgical scrub techs that are well versed in the world of sterility is all the nursing right now we need. We are able to handle the floor nursing, etc. By actually our nurses that we have that come with us in terms of that, but we definitely need operative room experienced nurses that are versed in the latest and the greatest, if you will, technology. So orthopedics, which is heavy trauma based right now, but there's a lot of secondary and tertiary cases that need to be done in orthopedics. Plastic surgery, neurosurgery, vascular surgery, ophthalmology and maxillofacial surgeries have all been needed because of the trauma. So we're looking for nurses that have that experience in those surgicals, if you will. ICU nurses are extremely important because most of these injuries still require significant impact on the thorax and the abdomen, and the patients are usually unstable for weeks on end that require the ICU care and can provide that expertise.
Do emergency room and trauma nurses qualify for any of those roles? We do a lot of ICU in the ER.
Yeah, so if you have the capability to manage a ventilator and be able to a patient that's ventilated, that's hemodynamically unstable, those are the ones that we need experienced nurses to be able to help with. Absolutely.
Thank you so much.
You're welcome.
And thank you, Leslie, for your question. To piggyback off of Leslie's question, can you speak a little bit more about the similarly supportive roles you need from like the paramedic, EMT, administrator, those types of positions we've spoken about previously?
So basically from the paramedics, usually that's handled in the communities. They actually have a good infrastructure for that. The EMTs are basically life-saving. They provide the key issues. They are extremely well trained. We are surpassed. I would say that they would surpass our EMTs here in the United States and Canada. Excuse me, having trained in both. And I would say that's not an issue really. Administratively, it's a very complicated situation. I would love to say, let's get a team of administrators that can organize the hospital, get the supplies room ready and up and running, but this is a huge ask. And as a result of that, it's very difficult to take this massive hospital, which has, I think about 400 beds, that's occupied by 20,000 people, and at the same time, allow, one or two or even three administrators. There's so much work that needs to be done. The only time it can really occur is when there's some peace or harmony where you can start bringing supplies in, restocking the shelves. As I said, we had to operate many a times with local anesthetic versus general anesthetic, which is obviously not ideal. Supplies are a huge issue. This is usually managed by administrators. The clinicians are handling the sequence of patients. We need space. There's no infrastructure to support a simple clinic, to do a women's health clinic, to do a orthopedic follow-up clinics. We literally had to do this in the open hallway and put a few bed sheets across. It is literally the most basic you can expect. And you can't just go outside and put a tent up because it's occupied by the 20,000 people that are living around Rafah in that area. Kanyun is very similar. There's no infrastructure. So there's no necessary, absolutely quintessential, if you will, infrastructure to support clinics. The surgeries that are available, ORs, there are about 7 of them for massive volume of casualties. If there's one bomb that drops in one place, as we've seen, then you have 50 casualties walking in with severe injuries. The resources are not available to do that. If you didn't bring it with you, then you'll not be able to be effective. And that was part of our frustrations, losing patients, dying in front of us. Most of them children with multiple amputations, because there's no alternatives for them, because we didn't have the supplies. And it's very, very frustrating. Dr. Musab has a case where his heart always goes out to it, and he shows it with a 13-year-old boy who just was in the middle of the night, got really hungry, so he went out trying to find some food around the tent. And he thought he'd seen a can of tuna or something that was sitting in front of one of the tents. So he went to reach it, and it actually blew up. He came in with injuries, in fact, in 4 extremities, but because of the degree of the injuries, all 4 extremities required amputation. We had seen also similar stories with 4-year-old girls. We've had doctors reaching out to us saying, this is severely needed. Amputation, 4-year-old, we need help, we need prosthetics, we need this, and we can't bring it in. It's very, very frustrating.
Wow, those are quite moving stories. And thank you for sharing those with us in answer to the question. I have 2 additional questions from John in the chat. The first is, and they're both a little more logistical in nature, but how do you handle language? If someone's, say, just an English speaker, volunteering in Gaza, what is FAJR's posture?
So actually, we were surprised. A lot of the locals have the capability to speak decent English. I wouldn't say communication. We have enough people that in the ground that we have volunteers from the medical students. Unfortunately, they have lost their universities who speak excellent English and are quite versatile in both Arabic and English. So we usually have them follow a clinician that comes, for example, we have people from Portugal, et cetera, that comes with us. And they are extremely, again, versed in our same protocols, and they are unable to speak Arabic. But because we have a physician, a medical student in training, or people that are just well-versed in English and Arabic, are able to communicate.
Thank you so much. And you do,
The physicians themselves are actually extremely well with English. I'm sorry, let me finish that. So the medical teams are fine. You can communicate with them. They're versed in English. They're trained in English. It's the trying to work, for example, with other tiers of the hospitals that may be a nurse that is trained in Egypt and now is back in Gaza and has been there for 20 years. She may not know the English and so on. So that's where we found the interplay with having the students is really a key component for us.
thank you for that clarification.
We appreciate the opportunity to share with you the challenges there. It's extremely challenging in every way to attempt and practice what we all train for.
Yeah, we actually have some people in the chat. So Pat, for instance, from Team Rubicon, so another NGO in the space, and Pat is saying that their team just tried to enter through the Rafah gate and could not gain entry. We have a question from John about how that's working specifically in Gaza right now, and then like how FAJR handles the transport of doctors generally. So I'm wondering if you could speak to those two related topics.
So my understanding, again, we're keeping a very close eye in terms of what information we get from the WHO. We are, for example, when we're part of the elite teams, if you will, because of the complex nature of the surgeries that we do. So we are updated. We get emails on a regular basis as part of the EMT group chat, part of the OCHA chats, part of the communications between the EMT groups and multiple other groups beyond the WHO. So as a result of that, we have this information. Now, what we know is that the Rafah border is closed. We are aware of that future missions will be coming through the Jordanian side. And in fact, our team was supposed to go in 3 days ago for this third mission, but has been delayed because that has not been worked out. There are already some information coming about, as I just shared with you, only 2 suitcases. You can't bring in 118 suitcases. I didn't see what the issues were back then. We thought it was reasonable, but ideally you'd like to have this shipped to the area that you're going to be working, but that's not the case. I don't know how the Jordanians is going to handle it. So we're watching and waiting. Our team is ready to be deployed. And that's the other thing. Some of the frustrations that occurred is that some of the doctors had planned to be there for 2 weeks and they, blocked another week afterwards to get caught up. Well, that's not going to work in a war situation. You don't know when you're going to get in. We had a lot of people, for example, that signed up for the first mission. And literally, as we're boarding the bus from the World WHO office to go into Rafah in Arish and then into Rafah in Palestine, they got pulled off the bus for whatever issue that was pulled up by the COGAT, saying, no, he's not cleared. And that was very frustrating. Last minute, imagine blocking off a month and then not having the capability last second, told that you can't go into El Arish. Very, very on Rafah, and it's very, very frustrating. By the same token, our teams were stuck in there for additional time and weeks on end because they couldn't leave because they had an incursion in Rafah and the Rafah border was closed. And there was no plan as to what to do after that. So we had to employ and reach out to our colleagues, et cetera, to prepare that. And right now, we're told that it's going to be through Jordan, yet no teams have gone through Jordan. And what we understand, the WHO is reaching out, not the WHO, I'm sorry, the Ministry of Health is reaching out to the various EMT teams saying, please come on in, we need some help. Because like I said, most of the physicians, locals, and nurses have fled because of the incursion into Rafah for the sake of their families. Very challenging. So basically the message is, if you are planning to be 2 weeks there, you may be stuck there for 3 months. And that is beyond our control. And only way we can control that, obviously, is to be in the decision-making process. But that decision-making process is not made available to the EMT teams that are on the ground.
Yeah, and I think based on some of the follow-up questions we're asking, I do think it's important to clarify that, you know, individual physicians are not flying over to Jordan to get into Gaza, right? With people should be operating under the umbrella of an NGO or an organization like Health Ministry, World Health Organization. Can you further clarify that?
Right, so we have, obviously, that's the point. You can't just get up and take your suitcase and go there. You're not gonna gain access to a war zone. That's the way it's been, you know, and that's sort of the rules of the game. You need an organization such as FAJR, to be able to, which has collaborations, connections, regular meetings with the, literally, we can pick up the call and, you know, a phone and call in any members of the necessary, stakeholders that allow you to get into a war zone such as Gaza. So that requires that it's not just one call. You're dealing with multiple, you know, stakeholders to do that. And even then, you may not get the access that you're seeking because of safety issues, access issues, political issues that are beyond you as an organization.
Yep.
Now, we've
Right.
opened it up partners with other partners that are willing to work with us. That is, you know, they have the expertise that can match the caliber of our physicians and nurses. And we have done so in a very limited capacity. But it really requires that, you know, these kind of expertise has to be done in a way that allows that, you know, we really got to maintain, again, we need to maintain the same line. We have to be on the same line, on the same page, in the same book when it comes to medical care, because the last thing we want to do is have, and we've seen it, actually, it wasn't in our teams, but we've seen other teams have conflicts because of that, literally in the hallways, where the ideology for one way to treat a problem is completely different in another country. And we respect it. It may work in that country, it may work in another country, but at the end of the day, we got to have this be on the same page in these issues.
Right, and just to echo that for the team here, so H1 does not endorse or encourage anyone to fly in the region on their own merit. You should be working within an NGO, as Katie mentioned, such as FAJR Scientific, Team Rubicon, or other groups. We definitely don't encourage that.
Yeah, thank you, Miles. All right, are there any other questions from the group? I'm not sure, Miles, if you're seeing any that I am not in the larger chat that we'd like to direct here.
Yeah, just a general question I see in the chat, Call. So, you know, you mentioned that it's easier to bring on physicians with Western experience because you know their training and all that. But, you know, if I'm a practitioner from Africa, you know, I've done a lot of these missions before, I'm well trained, but it might just be, you know, different training than you're used to. What can I do to get involved and help out? Like, is there a way I can work with FAJR Scientific? Is there another group you know of that I can work with?
So I can't speak for the other groups. I can just share with you that we do have a committee that's called the Credentialing Committee with FAJR. It's FAJR.org. Again, FAJR.org. On there, you will see an application form. We welcome you to look at to go in there and complete your application and your request and your experience. Please put that in there. There's a box that you can add this information. Obviously, people that are seasoned, that have you know, austere conditions, wartime experience, and have done it in whatever capacities they have been trained in, that supports all your application. This is reviewed by a comprehensive committee of about 8 people. It's not one person making a decision. This is a very detailed process. We want to give equal measures. We want to take the best to provide the best care, but we also want to get the opportunity for those physicians, nurses, physical therapists, etc., that are interested in coming, the opportunity to put their best foot forward to, if they can match the caliber that we're seeking to provide the top care, is critical. Ethically, we have to do that, right? So we can't compromise the quality of care for multiple reasons. As physicians, nurses, etc., we've taken, you know, an oath to maintain the highest quality of care based on what we know. We have managed risks and complications. At the end of the day, we actually have in every mission a chief medical officer, a physician lead. That's how much we take quality as part of our protocols. We take patient safety a critical issue. We rather than do no harm is very, very. In other words, we made decisions where we shouldn't be operating on a patient because we didn't have a supply A or medication B or whatever. Despite in being better conditions, that patient would have got an operation from one of us who are more than capable to do it. So just simply put, like on the first mission, we had 8 orthopedic surgeons on the ground to handle all the complexities, and we were busy nonstop around the clock. That didn't include, on top of that, vascular, etc. So again, put your best foot forward. If you're interested in looking at FAJR, please do. We welcome you. But again, do your due diligence, get your licensure, etc. Presented, share with them your experiences. I don't have the final vote, even though I'm the president. I'm happy to say that. I basically am just overseeing the overall process to maintain the principles and the working platform that we all must maintain ethically for everybody, so they all have equal access to come in.
Great. Thank you.
Great, thank you. So we are almost at time. If there are any other questions, drop them in the chat. But to kind of wrap things up, as those may trickle in, you know, we have posted the FAJR specific application on H1 Connect. We will share that in follow-up alongside a recording of this to those of you who are able to join today, as well as the people who are not. And again, what that does is allow us to kind of pre-vet, go through your credentials, and then send a list of qualified candidates off to FAJR. Any other questions here? I'm seeing, do we need to bring our own surgical supplies?
Yes, you do. The best advice that we were given before our first mission, which was completely, even when our first mission was in August 2023, was assume that it's a desert. And we literally had to carry our own saline bags into the country, which you can appreciate, it's a lot of weight. We couldn't, for example, ship it from here, but we literally had to buy it from surrounding regions and bring it into the occupied territories. So it was very, very frustrating to see that even an IV or a saline bag had to be brought in. So we take care of the supplies, but the surgical instruments, you need to bring your own. So if you're a microvascular surgeon, I recommend highly you bring your own set, ENT surgeon, plastic surgeons, vascular surgeons, even the orthopedic surgeons, we all brought our own preferred, our preferred protocols in terms of how we do particular surgeries, and therefore our team knew what we needed, opened up the right instruments that we have brought with us. And the supply room is a very big challenge. In fact, our team spent about 3 days, even the head lead of our mission, after I had left, Dr. Tariq Nafi, spent an entire 3-4 days organizing the supply room so we can find things. It was very, very frustrating. Disposables are a minimum. Yes, there's gloves, but they may not be gowns. If they may be gowns, they may not be head covers. So it was challenging, to say the best, to be to really practice at the top flight that we have been trained in. So that's really critical.
And then I think we have time for one final question from Pat. And it's, how about written protocols between the forward trauma points and the surgical hospitals for scope of care? That's a little beyond my purview, but I'm assuming you can answer that question.
So the protocols are going to be managed, obviously, by the teams on the ground. We have for each team a head lead. For example, ophthalmology has its own lead, ENT. These doctors meet before they come together to provide the care. There's accepted protocols for example, eye injuries, maxillofacial injuries. The lead, the director for each subdivision, takes care of the standard protocols. Vascular surgeons, etc. Vascular has its own division. Orthopedic joint replacement has a different division than sports medicine versus foot and ankle. Each of those are subspecialties. We're extremely organized so that we can contain the information. In other words, a general surgeon that is primarily focused on thoracic and abdominal injuries and maybe some urologic is not going to be doing an orthopedic procedure, because we have the expertise to do that, and they have protocols, specifically up-to-date protocols, because this is their realm of world that they practice, that they will be implementing.
Thank you so much. And we are right at time. So again, thank you for all of those who are able to join and for participating, asking your questions, and then call. Obviously, you are a very busy man. We really appreciate your time. And thank you so much for sharing your knowledge and information about FAJR with our network.
My privilege. Thank you so much for having me. And we're enjoying our relationship with H1. And I want to thank everybody that made the time to be on this conference call, and hope that I'll get the chance to meet you all.
Thank you so much.
Thanks a lot.
Everyone have a wonderful day.
Take care. Bye-bye.